So good morning, everybody, and thank you to Brian and Lucille for the opportunity to share with you this morning. I am going to talk to you about how to prepare for COVID-19 in South Africa. And I guess you can't hear me. Okay. I need to speak loud. The reason why you're all here is because you want to know, what can I do? How can I keep myself safe? How can I keep my patients safe? And at the end of the day, how can I contribute to the Southern African effort to contain coronavirus? So I'm going to start really with the broader context around what has been done so far by public health and other authorities, including the National Department of Health, ourselves at the NICD, and the provinces and metros. And then I'm going to speak about what you can do for your facility, the place where you work, and lastly, what you can do for yourself. And my take-home message really is that it all depends on you. As individuals, there's little that we can do, but when we work collectively and we take our own responsibilities and contributions seriously, we can conquer the world and we can conquer coronavirus. So, Lucille mentioned some of the broader global context, the evolution of the virus. What I'm going to put up and what is here is a slide that is borrowed from the influenza paradigm. People who worked in the influenza space were always terrified that there'd be a 1918 type pandemic. And they classified, the WHO classified stages of a pandemic or the evolution of a pandemic by describing phases. And they spoke about phases 1 to 3, which were essentially a virus that exclusively circulates in the animal kingdom. Phase 2 with some human infections, but no person-to-person transmission. Phase 3 was some person-to-person transmission and limited evidence, some crossover into the human species, but some evidence of person-to-person transmission. Phase 4 is heralded in this paradigm by the evidence of sustained person-to-person transmission. And once that happens, the WHO used a geographical way of describing the stages of a pandemic in a very artificial way. So phase 4, in phase 4, the human-to-human transmission is confined to a single geographical area or country. In phase 5, the person-to-person transmission is maintained in a single WHO region, but in multiple countries. And in phase 6, there's sustained person-to-person transmission with community-level transmission across 2 or 1 or more WHO regions. So you can see these are really artificial. But by the time stage 5 is reached, the WHO said, according to this paradigm, that this constitutes a pandemic. So why did they do this, have this classification? Well, it was very helpful to guide interventions. And so this is an excerpt from a table from the WHO where really they say in phase 4, our goal should be containment. And containment, the activities in containment are that we should direct and coordinate containment activities so as to limit or delay the spread of the virus. Phase 5 and 6, the role changes slightly, and that is to provide leadership and coordination to multi-sectoral resources to mitigate the societal and economic impact of the disease. So you can make your own judgments as to whether or not we're in a pandemic. The WHO seems to lag behind their own goals in the sense that, to the best of my knowledge, WHO hasn't declared a pandemic yesterday. I thought they had, but I was in error. But most certainly, we are clearly in phase 6. We have sustained person-to-person transmission in Italy, in Iran, in China, in a number of countries in Southeast Asia. There's no doubt about it. We, according to the WHO's own criteria, we are in pandemic phase. So where does that leave us in terms of what our actions are? We're very fortunate, as Lucille said, there are no cases, confirmed cases of coronavirus in South Africa at the moment, to the best of our knowledge. And with that context, it is appropriate that should we detect cases, that we adopt, as far as we are able, a containment approach. The extent to which we should go on to mitigation-related activities is a question for debate, but there's no doubt about it that regardless of where the world moves, our first few cases of coronavirus that we expect to receive here should be handled with containment in mind. So it's against that context that our South African authorities have formulated a plan. Now, this timeline, of course, has advanced significantly. Lucille showed an update, but the reason I'm showing it is really to add what the South African response has been at the contemporary global stage. On the 24th of January, our multi-sectoral national outbreak response team met with the awareness that the coronavirus was posing a global threat, and we sat together to do a risk assessment and start the process of planning a response. Our Minister of Health announced a public health emergency on the 31st of January, and from that moment on, our multi-sectoral national outbreak response team convened or activated the Emergency Operations Centre, and we have used an incident management approach in order to coordinate our activities, and it looks something like this. Don't worry about the detail. What you need to see is the top row. And in essence, whenever we have an outbreak of some kind or other, we approach it by identifying what are the key areas that need addressing in this outbreak, and we identify persons who can lead those key areas and work streams. And we then create a core team of people, and we meet regularly, and each of us continue with our own activities. So you can see that we're led by an incident manager who's from the Department of Health, Patrick Manassa, and Natalie Mayett is the Deputy Director of the National Institute of Communicable Diseases. She is the Deputy Incident Manager. The tracks along the top, starting from left to right. First, epidemiology and surveillance. You can appreciate we want to detect cases, we want to investigate them thoroughly, and when they happen, we want to identify contacts. So Dr. Walaza is heading that track. I'm heading the case management track, which includes not only management of cases, which I cannot do, so I'm not a clinician, but we have a group of expert clinicians led by Dr. Jeremy Nell, who is assisting us in this space, but also infection prevention and control and facility readiness, critical, in order to be able to prevent nosocomial transmission. The third area is communications. Lucille mentioned an absolutely critical part of any outbreak response. Laboratory diagnostics are an important component of case detection and response. Ports of entry, critical because we anticipate that this virus is going to be brought in from overseas. Management and coordination and emergency medical services. So I'm going to give you a quick cook's tour of what we've done so far. So with regard to epidemiology and surveillance, we set out to develop what's called a case definition, and this is something that we've circulated widely. The case definition is contained in guidelines, which may be found on the NICD website. We have a 24-hour hotline to support patient investigation, and if you don't know this number, put it in your cell phone. We also started a public hotline, and we developed data collection tools for people under investigation and for contact tracing. The case definition you're going to hear more of in other presentations, but in essence, it requires any symptomatology plus a travel history to an area where there's community transmission. Now, when we started, the community transmission was in China, but that, of course, has expanded, and we expect it to change weekly. With regard to case management, this included very critically guidelines for quarantine of asymptomatic travelers who have returned from an area where there's community transmission. Now, there is fierce debate raging within the department and continent-wide as to whether or not persons who have returned from an area where there's community transmission should be asked to quarantine themselves for 14 days. And so this guideline, this algorithm has not seen the light of day. There is no official standpoint on from the Department of Health as to what we should do with persons who have returned from an area of high risk transmission. And the question that we really want So in other words, it's an open space at the moment. Some countries have adopted extremely conservative views, like the United States, where they've enforced people who return from an area of high transmission to undergo and remain in quarantine for 14 days. Others have adopted a more laissez-faire, human rights-centered approach by saying that individuals can choose whether they want to self-isolate or, quarantine. And others have said, and our guideline was going to go along these lines, that you can return to activities of daily life, but monitor yourself for symptoms, and at the first sign of symptoms, self-isolate and seek care. One of the challenges in deriving an algorithm like this are the questions around transmission. To what degree is asymptomatic transmission responsible for onward spread of the disease? It's not really known for sure. Biologically, highly unlikely that a significant amount of transmission happens when people are asymptomatic. We know in order to transmit, you have to have a high viral load, and you only can get a high viral load if you've got replication of the virus, and when the virus is replicating, people are generally symptomatic. So difficult to make guidelines in this space, but watch the space. Hopefully things will develop. The other thing that we've done is developed a facility readiness checklist, and this is available on the internet. This is something that I'll come back to later. We've also supported training activities in the province, and we've intensively focused for the moment on the 11 designated hospitals. Now, of course, we know once we have community transmission, the 11 designated hospitals are going to be immaterial. And so as our 11 designated hospitals are more ready and meet readiness checklist criteria, we're moving on to lower tiered hospitals in the health system. The Centre for Respiratory Disease and Medicine, Respiratory Disease and Meningitis in the NICD has done a superb job of ensuring that we have diagnostic capacity with validated, internationally validated tests and a number of different test methodology. They've also been instrumental in supporting specimen collection and transport, and they have conducted, as of last week, a total of 69 tests, with all having been negative. The reason why the number is so few is we have made a principled decision along with the rest of the world that we will only test persons meeting our case definition. Now, our case definition includes a travel history to China. I've just been informed that France has changed the case definition to include certain kinds of severe pneumonia in addition to persons who have a travel history. And the reason for that is they're trying to look for community level transmission that they may have missed. There is a likelihood in the next week or two or month that we may also do such a thing. But we need to consider very carefully what the implications of such testing are. And so again, watch this space for the case definition. Communications are key. Our communications officer has really done a superb job in coordinating our responses. We like to have a handful, a single one or two key communicators, and you will have seen Prof. Cheryl Cohen and heard her on the radio, and Dr. Walaza are our two key people who are communicating messages to the public in a consistent way so as to support the building of trust and a reliable information source. Our ports of entry have been superb in responding with strengthening their screening processes. The Civil Aviation Authority has conducted training of nearly over 900 airline staff, crew, ground staff, etc. So our ports are covered. From a security perspective, there's a National Security Committee called NatJoints. It's convened by the South African Police Services. We are feeding information into there daily, and the head of our emergency medical services is chairing a subcommittee on NatJoints. So should it be required to make quarantine, close institutions, etc., this is the structure that is going to oversee those key decisions. There is also a possibility we may evacuate citizens from China, from Wuhan, and again, this is the organization that is going to do this. It's critically important, as Lucille has shared, that we keep update with global developments, and Lucille and Cheryl Cohen and a number of others of us are weekly participating in outbreak response meetings so that we're able to change and respond to and learn from the international experience. What can you do? Why are you here? Well, there are a number of things that you can do, and here is the checklist. The first is, there are two broad categories. The first is ensure that your place of work is ready. And the second is ensure that you are prepared and respond appropriately when a patient meets the case definition. So let's go into a little bit more detail. How do you see that your facility is ready? On our website, and the link is there, you can download a facility readiness checklist. It basically looks at several intervention areas: coordination, surveillance, rapid response, lab procedures, infection prevention and control, case management, risk communication, and logistics. If you run a GP practice, you can use this facility tool. If you belong to Morningside Hospital, you go to your CEO and you say, do you comply? And why do you do this? Because it's in your own interests. You do not want to be caught by surprise suddenly examining a patient with pneumonia, and then only afterwards you discover from the relatives, actually they just recently arrived from Hong Kong or from Iran. So ensure your facility is ready. The next thing you can do is have in your practice specimen collection material ready. So there you can ask your partner, your laboratory partner, whoever that is, Ampath, Lancet, etc. And very importantly, it's not just about collecting the specimen. We also ask that people who collect the specimen firstly phone the NICD hotline before you even take the specimen to find out if we're going to test this patient. Secondly, you need to complete a specimen request form that goes to the laboratory and a patient under investigation form. Why? Because we're intelligent about the way we collect data on these cases. We don't want a collection of specimens with only the name and the gender and the address. We want to know who are we testing, where and why. And you can contribute by doing this, by cooperating and supporting our endeavor. Thirdly, your facility needs to have IPC and isolation areas. So at the reception, at the security entrance where the cars drive in, you need to have a sign that says, have you traveled in the last 2 weeks to an area where new coronavirus is circulating? Please let the receptionist know immediately. Because why? Because if that person has respiratory symptoms, you want to put a surgical mask on them, not an N95 mask, a surgical mask, so that when they cough, they do not share their germs with anyone. And you also want to be able to triage them. You want to see them immediately. You don't want them to sit and wait in your emergency department or your waiting room. And you want to ensure that you yourself are aware of what you're dealing with when they come to you. You need to have updated guidelines and case definitions on hand and be familiar with them. Like Lucille said, they're changing from day to day. It's no good to know that the NICD published a case definition 2 weeks ago. You need to keep your finger on the pulse. Lastly, you need to know the referral pathways. Very complicated diagram. Appendix 3 of the guidelines that are found on the website has this beautiful, simple flow diagram. If you look at it, you'll know exactly what to do. I know you think it's not simple, but it is. So very easily, does the patient meet the case definition? Yes, you need to test. There are 3 options, things you need to do, and it's all laid out for you there. I'm not going to go into it. Lastly, what if you have a patient that tests positive? Apart from panicking. Okay, no panic. Apart from panicking, you need to start the process of contact tracing. You yourself are a contact. You need to know what to do. Your staff, receptionists, and people in the waiting area, if you didn't follow the IPC instructions and facility readiness, are contacts. That person's family are contacts. Now, at the moment that you decide to take a specimen, you need to start thinking, if the specimen is positive, what do I need to do? First people you need to call, but the NICD will facilitate this, is your provincial coordinator who will help you with contact tracing. Secondly, Appendix 5 or 6 or 9, Appendix 9 in the guidelines is a contact tracing list. You can fill it out for us. That would be the best thing you could do for the community, for your patient, and for yourself. After that, the NICD will guide you, or your communicable disease coordinator will guide you. Last 2 slides, what can you do for yourself? If you're a healthcare worker, don't let people meeting the case definition catch you by surprise. Screen, isolate, triage. Secondly, take the flu vaccine. Simugile is going to talk to us about why we should do that. Ensure your rooms are well ventilated and that airflow direction is from your back to the patient. Eat, sleep, exercise well, and don't let the pressures of the job get you down. Keep your underlying illnesses under control. Self-isolate and test if you've been exposed to a confirmed case and you develop symptoms. That has serious implications for us who are in the healthcare profession. If we self-isolate, it cannot work. So we need to be cautious. The guidelines are that if we've been wearing appropriate post-exposure prophylaxis equipment and following IPC, as Kim is going to share with us, we don't need to self-isolate. And therefore, we just need to watch for onset of symptoms. So if you were adequately protected when you are exposed, your risk is minimal. If you're a member of the public, the same. Take the flu vaccine, eat, sleep, exercise well, keep your underlying illnesses under control. And remember, in addition to being healthcare workers, we are also members of the public. Not so? Practice cough hygiene, hand washing. The dominant mode of transmission, as Kim is going to share with us, is likely to be fomites with auto-inoculation through the mucous membranes. Hand washing is critical. Encourage persons who have respiratory symptoms to self-isolate and test. There are so many resources to assist. This is a lovely document, Guidelines for the Use of Non-Pharmaceutical Measures to Delay and Mitigate the Impact of COVID. The reason why this is a helpful document is it speaks to the use of masks. So the reason why masks have gone up in price is why? Because of the manufacturer's greed and self-interest. There is no need for members of the public to walk around wearing a mask, a surgical mask. There is no evidence that it delays or mitigates the spread of a virus through a community. And lastly, coronavirus has been around for a long time. This Asterix comic was published in probably in the mid-50s. And this is a scene from a race, and they are frightening this person on to win the race by shouting out, "Coronavirus, coronavirus!" and let the same spur us on. Thank you.